Hello and welcome to another episode. Today I am joined by Dr. Anton Clough, who is a podiatrist and the principal podiatrist at South Perth Podiatry, and he's also the chairman of Podiatry WA. Anton has been a part of the community of South Perth and surrounding suburbs for over 34 years, and in this episode, Anton shares his insight into lower limb pain presentations. So let's dive right in. Anton, thank you so much for joining me on today's podcast.
You're welcome. Glad to be here.
And I've seen that you've got over 34 years experience as a podiatrist. So in that time, that's a lot of feet.
A lot of feet. Well, two pairs if everybody comes in. So, yeah.
And even more toes.
And even more toes. Yeah. Yes, the numbers just keep getting bigger.
Fantastic. So we'll dive straight in. This is a topic that I'm really interested to talk to you about. You know, it's fantastic to be able to speak to a podiatrist, an expert in the lower limb. So can you just kick us off by explaining some of the most common foot and ankle conditions that you would see in clinical practice?
Okay. So, from my perspective, I've been in general practice, I guess, for a long time. But I see a whole range of things from general foot care through to sports injuries, excuse me, from pediatrics to now in recent years, more chronic pain stuff that I've been dealing with. I also do, like ingrown toenail surgery and wart surgery and stuff like that. So I've got a fairly broad practice, which is great. But I do have an interest in biomechanics, sports injuries, and pediatrics. So that's where I'd probably fit in. And so going along with that, I guess the common things that I'll see are things like plantar fasciopathy, neuromas, things like posterior tibial stress syndrome, and also severs is a very common thing I see in the teenagers. So those four are probably the more common things that I would see in my practice.
Oh, fantastic. You mentioned ingrown toenails. That I've had one of those, and I tell you what, that's one of the most painful things I've had in my life.
But they're great fun treating them. So, and they're good. We can fix them. So that's good.
Yeah, perfect. Okay, and so you mentioned plantar fasciopathy. I mean, that's a
Yeah.
really interesting topic, isn't it? And it can be quite a confusing one and potentially one that's mismanaged or even misdiagnosed. So can you talk us through a little bit more about plantar fasciopathy?
Okay, so I guess probably what we should from the start is try and define it, because there's words have been thrown out like plantar fasciitis or fasciopathy or fasciosis or things like that. So I guess I've come up with the definition that I'm comfortable with in what I see clinically. So I'd say plantar fasciitis is probably an acute presentation of a fasciopathy, fasciopathy being a broad overarching term. And so when people present with a very acute symptom, they've got very acute sharp pain, all the usual sort of things people see, I'd say that's a fasciitis. But fasciopathy or fasciitis usually develops into, and what a lot of people see is fasciosis, which is more the chronic degenerative stage of fasciopathy. So I'm happy with that definition of saying there's an acute phase and a more chronic phase of sort of plantar fasciitis. And plantar fasciitis is used as an umbrella term as well, but I prefer fasciopathy as an umbrella term myself. So given that we've got those two different definitions, obviously that also determines how you treat it as well. Because if you've got an acute phase, you want to probably treat it in a more of an acute manner. If you've got a chronic stage, you're doing different things. You're treating it differently. But ultimately, the whole idea is to relieve pain, from that sort of situation. So, yeah. So does that answer the question, I guess?
Yeah, great. And so what are some key indicators that may tell us that there is a plantar fasciitis or a plantar fasciopathy there? What are the key signs and symptoms that a patient may complain of?
I guess the other thing, sorry, before we go into that, the other thing I guess we need to define about the fascia is that, fascia is not an inert tissue. I guess a lot of your listeners will understand that in the past it was considered an inert tissue that didn't do anything. But of course, we know now that it has smooth muscle, it's innervated, and it has an ability to be an active tissue. So the fascia, the plantar fascia, obviously is a very thick, broad band of this tissue, but it still has those components in it. So it's an active tissue and it's dynamic. And so from the point of view, when you're coming in and seeing a clinical presentation, you're looking at obviously pain. So people who've got heel pain, usually it's central, maybe a bit more lateral or medial. So, just because it's not in the right spot doesn't mean it's not. Usually things like if they're getting up in the morning, first thing out of bed, that's a very key indicator, that first rising pain, which is very typical. They could also do that if they've been getting out of a chair or something like that sort of thing as well. So those kind of things are pretty typical. Things like increasing pain with increasing standing. Standing is particularly bad for this particular problem. We know we're not designed to be columns, we're designed to be functional. And so, standing for long periods of time can be one of the things that can induce a lot of fascial injury. And obviously it could extend not just in the heel as well. Of course, it can extend through the entire fascia. So obviously when you examine the patient, you obviously need to check the entire length of the fascia. They can have nodules, they can have fibromas in the actual fascia as well, which impact on the function of the fascia. So things like that you need to gauge when they first come in. But key takeaway is, central deep bruising or sharp pain in the central heel, tenderness on first rising. That often doesn't respond to anti-inflammatories. So that's almost another diagnostic test. If people are saying, I've been taking anti-inflammatories and my heel pain is still bad, it probably is plantar fasciitis or fasciopathy.
Yeah, okay. And so are there any other sort of key factors that we need to look at as far as, changes in unaccustomed load or footwear or anything that sort of may contribute to the onset of these symptoms?
So obviously it's a soft tissue problem. Initially, when it goes into the more chronic fasciosis kind of symptoms, you can often get bone edema as well. So it then becomes a bone problem as well. But obviously initially it's a soft tissue issue. Interestingly, also as it gets into that degenerative stage, you get loss of collagen and loss of blood supply to the area, which then, feeds into that whole, that's where you need to do your more chronic management. So in terms of what we need to do for it, you're looking at things like managing it from a functional point of view, because obviously it's a functional problem. Usually it's biomechanically based. So from my perspective, when I see someone with a fasciitis or fasciopathy, I want to actually test their biomechanics first. So I assess their biomechanical alignments, the very key thing. Check for things like leg length differences, which can cause uneven loading through the feet. So it's quite common to see it in the longer side of if you've got a long leg. It's usually on that side because they're usually hyperpronating more on that as a compensation. So that's one thing I usually check for. So things like obviously how they're standing, if they're hypermobile, if they're hyperpronated, that's obviously going to load up the fascia. Things like tightness in their structure, so posterior chain tightness, hamstrings and calves, particularly calves, you need to make sure that they're not too tight, because obviously that's going to force their fascia into the sort of propulsion phase, is going to actually add more load into the fascia. So those are sort of several key things that I look at when someone comes. When I've made a preliminary diagnosis of plantar fasciopathy, then those are the things I really start looking at, and I try and eliminate the biomechanical aspects first, and then if it's not responding just to that, then obviously then we go into all the other treatment options that we have available to us.
Yeah, great. So what are some sort of short-term interventions that you could do as far as, those biomechanical corrections to decrease some pain? What does that look like?
So for me, initially, I do a lot of strapping. So I do a lot of low-dye taping, which basically it's manipulating the first metatarsal into a plantar flex position, which is obviously going to help offload the fascia. Because the fascia, I guess we have to also understand the mechanics of what the fascia is doing. It's actually used to tighten up the mid-tarsal joint structures at propulsion. So at propulsion, the hallux is fixed on the ground. And as you propulse forward, the fascia acts as a windlass mechanism. It's called a windlass mechanism, and it pulls the calcaneus hard towards the metatarsals, which then compacts the mid-tarsals. Now that makes the foot a nice rigid structure, rigid lever, so it increases efficiency at propulsion. If you've got a very hypermobile foot at propulsion, obviously it's not very efficient in delivering that energy to your propulsion. So the fascia has to be in a functional position for a start. And so if we understand that mechanism and we can actually then try and control it biomechanically, put the foot in a more efficient position, and that's what we do with the low-dye taping, often they'll get a significant reduction in their symptoms. And I usually test that for a week. They come back after a week, and usually they respond by saying, I've had either complete relief of the symptoms or at least sort of 70 to 80% relief. Now, it may not maintain when the tape comes off because their foot returns to its poor function, but at least we know that there's a biomechanical component to that. So that's one thing I have to always address.
Yeah, great. I've used Lodi a lot, and it just works wonders, doesn't it?
Great. It's a really good testing tool for that. Yeah.
Okay, fantastic. So where do we go from there then? If you know there may be, I guess, using Lodi as a short-term intervention to unload that fascia, decrease some symptoms. What does it look like, you know, from the, say, after that initial phase? Where does the management progress to?
So once we've established that there is a mechanical problem, so obviously from a podiatry point of view, and I'm interested in biomechanics, I'll start looking at orthotic therapy as one of the tools that I use. But it's not the only tool. I mean, I use a lot of manual therapies. I'm interested in musculoskeletal treatments, and so I do a lot of instrument-assisted soft tissue mobilization, so using the rock blades and things like that. I do a lot of acupuncture and dry needling, particularly releasing the posterior chain. So, releasing that posterior fascial chain is really important. So doing all that sort of stuff as well as an adjunct. I'll do things like I use rock tape as well as the rigid tape as well, those sort of therapies. Ultrasound, I use low-level laser. I'll do some massage sometimes to release some structures. So basically, once you've established there's a structural mechanical problem there, you also have to treat the tissues around it because obviously they influence the structure as well. So it's so your listeners, that it's very important for them to release those structures and get things back to a functional range as well. So that's very important.
Yeah, great. And that's what I think is so interesting, is, it's going beyond that, the foot and ankle region, and you mentioned that whole posterior chain and addressing other areas within that kinetic chain, which is really important. And I think that's often a misconception that many people have around podiatry, is that you only focus on the foot, right?
That's right.
A bit more to it.
I think certainly that's probably one of the misconceptions or myths out there, is that podiatrists just cut toenails. But it's an interesting one because, yeah, I mean, we've evolved over as has been one of the biomechanical specialists in recent years, and that's one of the things that we provide as a service, is biomechanical assessment and orthotic therapy if required. But yes, I guess we do look at the whole. It's a holistic. I mean, from my perspective, certainly I look at the body as holistically, as a whole functioning kinetic chain of movement, of which the foot and ankle and leg are part. So I see a lot of knee injuries and hip related issues as well coming back to the foot. So again, I don't ever treat the foot in isolation. They might have a symptom there, like they might have a plantar fasciitis, but when you question them deeper, they also find that they'll have, knee pain, they'll have some hip pain or lower back pain, and all of it's related. So you can't treat anything in isolation. But if you're treating a particular symptom, then obviously, you would ought to work on those tissues around it as well.
Yeah, fantastic.
It's thinking more globally when you're treating a patient. I think you have to be, certainly from a biomechanical and a kinetic perspective, you have to do that.
100%. And so what's your biomechanical assessment look like? Is this something that can be done in clinic by observation, or do you need to have more high-tech tools and different programs, or what does that look like for you?
Well, high-tech tools are great. They're always fun to play with. Not always useful. Your eyes, I think, in your hands are your best tools, I think, in that sense. I personally have an assessment which I do for 45 minutes when I'm assessing someone's biomechanics. And basically I start at treating the body holistically. I look at the whole posture, I look at their whole gait. I stick them on a treadmill and I'll video their gait. I'll do balance assessments. I'll do, neurological assessment. I'll do muscular assessments, weaknesses, testing for weaknesses and tightness. And then looking at functionally from the whole body. So from, the feet all the way up to particularly concentrating on the, around the pelvis and that area. So having a look at that whole postural alignment issue. So it's really looking at the body as a functional entity. And so we're trying to then gauge what might be influencing the poor posture or the poor mechanics, or what might be restricting them from doing a certain movement, and then trying to eliminate those things as we go through. And as I said, orthotics is part of that. They're a tool, obviously to use, but they're not a panacea. They don't fix everything. That's probably another misconception. And a poorly made device and a poorly designed device will cause more problems than it will fix. And so it's very important to make sure that when you're dispensing an orthotic, that it's actually prescribed correctly for the person, and it's not just a throwaway. Some of the off-shelf devices are actually pretty good, but they need to be modified to the patient. They can't just be taken off the shelf and chucked in the shoe, because they're not gonna work.
Yeah, the old go down to the pharmacy and just cut out the right shoe size and slip that in.
I guess the difference is between a functional device versus an off-the-shelf device is that one is obviously prescribed for you, like glasses would be, and if you can go to the pharmacy and get a pair of glasses off the shelf for $20 and they'll work, but are they doing you any good? And the same with an orthotic. Orthotic can seem to do okay, but is it actually helping in the long term, and is it creating some long-term problems? So and they need to be obviously assessed, and modified. It's not just something. It's not a set and forget. The patient needs to be reviewed at a regular interval, usually annually, to make sure that the device hasn't broken down or they're still functioning properly.
I think that's such a valuable takeaway. When if a patient's presenting with an orthotic that they've had for several years, it may not be right for them anymore. It may be that they do go, it served its purpose for a period of time, but it may need to be changed or adapted or removed. But yeah, that's a really great.
Or it may never have been good for them.
Right.
So if they're having a lot of pain, one of the first things, and they're wearing an old orthotic, one of the first things I'll do is take them out of the orthotic, put them in a low dye tape, and see if their symptoms improve, and then put their orthotics back in. And if they get pain back again, then definitely you've got a problem with your orthotic. And so that needs to be either changed, modified or replaced.
Yeah, great. And so, you mentioned before on how important that assessment is, and, how important that comes into the overall management, getting the correct management early on. And far too often we see these presentations, go on and turn into chronic presentations that it may have just been missed early on or mismanaged. So I guess that's the real importance of involving podiatrists in the management of these conditions. So I just want to get an idea of what's the general, and I know it's hard to put a time frame on this, but when we look at prognosis of a plantar fasciopathy, what's a usual time frame that we're looking at?
When I get to see most of my patients, they've usually had it for at least a month as a minimum. You get some of the acute cases that come in because they're in a significant amount of pain. But a lot of people, it's not that bad. They can still function. They're hobbling around. They're trying to manage as best they can. But usually it's months before. They might have seen the doctor. They might have taken some anti-inflammatories. But it's usually months. And so they've gone past usually the acute phase, and they're starting into the degenerative fasciosis kind of phase. So in terms of how you sort of manage that and the prognosis, you're looking at, in the acute stage, usually probably a couple of weeks if you see them really acute when you start management. And then after a couple of weeks, it usually then evolves into the next phase, which, they've got the repairing phase that kind of overlaps with that sort of inflammatory acute stage. And then that can last between weeks and months, depending if people keep re-injuring it. So if they're still doing the same thing, they're still going for their walks, or they're still jogging, or they're still doing things that are aggravating it, obviously that's going to set it back each time. So it can drag it out, for many, many months. And then once they've got that through that phase and they're going into the sort of repair phase or the remodeling phase, that can obviously then take months once the collagen is starting to be laid down again, and starting to realign those fibers and things. So obviously that can take months. But again, if you're doing things that are re-injuring it, you haven't done something to ameliorate that, then you're going to sort of regress again.
Yeah, right.
So it's often months. So with no intervention, I mean, I've seen people who've had it for 18 months and more, and they've kind of been hobbling around and doing things. It's not obviously bad enough for them to really dive in and do something about it, but it's become chronic. Other people I've seen within 2 weeks of them developing it, because they're in so much pain they can't put their foot down.
Okay.
And so it depends on where they're at on that stage. But I would say most people, if I'd say most people that I see with a fasciopathy, I would say that they're usually functional and probably at least 80% better within 5 weeks, 6 weeks.
With the correct.
That's using orthotic therapy and all the other manual therapies that we're talking about. And obviously it's individual, you case manage each patient. And so you don't do every single thing to every single patient, but obviously you decide what's best modality is going to help them.
Yeah. Okay. And so, I mean, this is a challenge that I've had, and I'm sure many others out there have had this same problem. When a patient presents it, they said that they've had this heel pain for, 12 months or longer. And it's a real challenge. I guess that's where it's at that fasciosis stage, more of a degenerative phase. What does the management look like in those types of people? Because I guess we just feel a bit stuck. What do you do?
So again, it's obviously you're using those sort of treatments that you would for any chronic condition. So you're using heat, you're doing gentle mobilizations and stretches, and you're doing basically a rehab program with those clients. Again, because I'm biomechanically based, I would also check if they had an old orthotic, if that's actually still working or functioning, or if it's actually contributing to the problem. So if it is, I'd obviously get rid of that. I think from what podiatrists can offer in that realm is that quite often chronic problems are a result of poor mechanics not resolved. So you can treat the tissue, you can make it stronger, you can lengthen it, you can reduce pain through the tissues, and that'll work for a couple of weeks and it'll feel good or maybe a day, or might even for a few months. But when they start going back into activity or trying to build up again, it keeps coming back, and they get this chronic sort of cycling. And I think from a podiatry point of view, if you fix the mechanics, if you fix the biomechanical aspect of it, those tissues aren't going to be loaded excessively, and that's you're going to have long-term results, I guess, because it's all about tissue loading, right? Soft tissue injuries are all about excessive loading, either too quickly or chronically. It's exceeding what the tissues are capable of tolerating. And so where biomechanics and where orthotics come in is that it changes the mechanics of how your foot functions, and your whole limb functions, in fact, and therefore unloads the tissue. So the tendons, the muscles, the ligaments, all those soft tissues that are supporting those structures aren't loaded as much. So chronic ones they'll probably need some biomechanical intervention, and the acute ones also would benefit ultimately if that's what's causing it for them. But definitely chronic ones will benefit from that sort of therapy.
Okay, so the biomechanics is the real key here, and getting
from my perspective, I think I mean obviously everyone comes from a different angle, how they've been taught and where their interests lie. But I really feel that if you don't fix the underlying, I use this analogy: if the foundation of the building is crooked or weak, the building on top of it is never going to be stable or strong. And so if you have a stable base, a stable platform to work from, then everything else can work from that. Now, obviously, there are people that obviously feel that from a pelvic point of view, or from chiropractors from a back point of view, that will influence the other way. And it can. I mean, obviously, I'm not sitting here saying that everything comes from the feet, but I know that a lot of postural and gait related and sports related injuries start at that point. And if you don't have that stable base, everything else is going to keep getting re-injured because it's trying to support those structures. It's trying to retain or stop or prevent movement excessive in certain directions. And so they get overloaded. And so, but again, it's not a panacea. It won't fix everything. It's just one of the tools that you can use to help push, things in the right direction.
Yeah, okay, that's great advice. And so, I mean, how important then is footwear? I mean, there's all different types and shapes of shoes out there, some that are really super supportive and some not so much. How do we get the right shoe, and I guess how important is that in a patient's foot and biomechanics?
So very is a short answer to that question. Most people that I see, most people have shoes that are too small for them.
Mm-hmm.
They're either too short or too narrow. I don't know if it's an affectation of fashion where people, they don't want big clunky shoes. They want neat, sort of nice looking shoes. Or if it's habit that people feel that they're more secure in a shoe which is a bit tighter around their foot, and it gives them more security and more support. They feel gives them more support. But that's wrong. I mean, you need to have, particularly when we're talking about the forefoot, you need to have, say, at least a finger width, about 10 mil from the end of your longest toe to the internal dimension of the shoe, so on the insole. And obviously your width, you have to have a correct width. You can't have it too narrow and squeezing up your foot, because that causes a whole range of foot issues. I mentioned neuromas at the start, one of the things I see quite commonly. And the shoes are one of the biggest variables in causing that, apart from mechanics as well. But shoe tightness is one of the biggest factors. So shoes need to be roomy in the toes, or roomy enough that you're not constricted in that area, but obviously firm around the heel and around the middle of the shoe, so you can lace it up. You can anchor the foot at the ankle and the rear foot, and you got your stability from there, but you've got space in the front. And so obviously lacing techniques also come into that, and how the shoes lace, because some people obviously have prominent bumps around the mid-tarsal joint region, which can lead to neurological, so nerve compression issues, or the dorsalis pedis nerve that runs through there. See that quite commonly as well. Mm-hmm. So shoes, have a big variable. And then obviously if you're talking about using them with orthotics as well, that's another problem that people have, is that they often get a shoe that's too controlling with an orthotic. So you get two controlling devices, a shoe and an orthotic together, and then you have all sorts of trouble. You have a lot of pain. So, most shoes that you need with an orthotic is a neutral shoe, so not an anti-pronating or an anti-controlling shoe. So that's one thing that probably people should check when they've got clients in there, is what type of shoe they got. Is it a particularly controlling shoe with their orthotic? It's probably going to cause problems.
Okay, that's really interesting. When so much of it now is based on fashion and not necessarily what's right for the foot. And so, can people just refer on to podiatrists to have these fittings to get the right shoe?
Yeah, yes, I think there's, I guess there's some podiatrists obviously specialise in, I guess you'd have to get to know your local podiatrists and see what they work in or what areas they specialise in, because some are high risk management people, so they'll do, diabetic feet and things like that. I mean, like I said, personally, I don't do any of the high risk stuff much. I'm mainly concentrating on, as I said, the sports and pediatrics and chronic pain management now, where I do a lot of the acupuncture and dry needling and things. So if I guess aligning your practices with who you see is probably important. But yes, seeing to an appropriate podiatrist would be good, because then they can look at, obviously their foot problems relating to the actual mechanics of their foot. Hockers have become very popular lately. Again, it's become a bit of a fashion thing, and hockers again don't suit every type of foot. They are good as in the right situation. That rocker sole kind of effect. So if we're talking about specifically about plantar fasciopathy, that can be quite effective in reducing the load through the fascia, because you're rocking through. You're not really going through that heel toe motion that you would in a normal sort of shoe. So so they can be helpful, but obviously New Balance and Saucony, and they make a variant of that kind of rocker sole as well. So again, you can look around and try different shoes and see which is most comfortable. Going to places like Athlete's Foot and things like that is actually quite useful, because they do actually measure and fit your foot. for width and length, and they carry different widths and lengths. So, down to your local Foot Locker is not necessarily the best place to pick up your shoes. And the teenager there that's selling the shoes doesn't really know much about it. So, it's okay if you know your particular shoe and you found one that's really comfortable. Okay, you can go for the same model. But if you're not sure, then probably going to those fitting places. Is Runner's World or Keep On Running is another place here in Perth. They're both very good at fitting.
Perfect. And I think, there's so many really useful takeaways here. And I guess just getting the right management early on can prevent, foot and ankle, lower limb injuries getting a whole lot worse. So Anton, thank you so much for your time and your valuable knowledge. I really appreciate it. And I'm sure our viewers and listeners really appreciate it too.
Oh, it's a pleasure. It's been great talking to you, Bo. And if anyone has any questions, that result from this, I'm happy to fire back my answers. So,
Perfect. How can people get in contact with you?
or you can go through my email if you want to share that at the bottom, or you can leave my practice details and they can call me directly. I'm quite happy to chat over the phone. So, yeah, more than happy.
Excellent. Again, thank you so much, Anton. Really appreciate it. Thank you very much.
No problem at all. Have a great day.